Cool. So let's start doing cardiovascular pathology. So cardio is really fun. There's a lot of disorders that affect the heart. These are things that you're going to definitely see in the hospital. You know, hypertension, hyperlipidemia, MIs, right? Myocardial infarction. Those are all things that you will see all the time, right? Especially here in the United States, places that have a Western diet, people who are very sedentary, they don't get much exercise, right? People with untreated hypertension, untreated hyperlipidemia, untreated hyperglycemia, all those things are contributing to cardiovascular diseases. So this is like bread and butter stuff. You'll see lots of infectious diseases when you're working in the hospital. You'll see lots of cardiovascular diseases as well. So this is like bread and butter type medicine. Anyone seen this movie? It's like one of the best Indiana Jones films. You definitely got to see it. So he pulls the heart out of the person, and it still beats, right? So you probably remember from back in A&P that the heart has the ability for automaticity, right? It's like automatically beating. When I was an undergrad, we did this ghastly experiment, bless you, where we removed the heart from a live frog. I mean, it was terrible. Actually, if I were to go back then, I probably would refuse to do the lab because it was ghastly. It was anesthetized, the frog. But regardless, it was pretty mean to rip the heart out of a frog just so we could sit there and watch it beat and see how long it beat it for. That was the purpose of that lab. And my frog, the heart beat it for 21 minutes. I'm like, okay, cool. We could have read about that in the textbook. We have to kill the poor frog just to see how long the heart beats outside the body. But anyways, if you take the heart out of a person, the heart will continue to beat, right? Because you have the SA node and the AV node, and those are what allow for depolarization of the cardiac myocytes. And you probably remember all the circuitry from the SA node to the AV node and the Purkinje fibers, bundle of His, and all that stuff. You guys remember all that, right? Okay, good. So yeah, the heart can beat by itself. And so pretty cool stuff. It's a very cool organ. So these are all the things that we're going to be going over. I divided this whole entire series into 3 sections. So we're going to go over part 1. Part 2 and 3 we'll go over next week. So lots to go over, but most of the stuff that we're going to talk about is going to be right over here. We're going to talk a little bit about costochondritis, atherosclerosis, angina, MI, heart failure, etc. And then for the next week, we'll go over all this other stuff. So, costochondritis. The reason why this falls under cardiovascular is because of this. It can look like a heart attack, but it's not a heart attack. In fact, all it is just pain and inflammation of the cartilages in your thoracic, in your thorax, right? That's what costochondritis means. So it has to do with your costal cartilages. Of course, you have several cartilages, right? And they attach the sternum to the ribs. And if you had any sort of injury or trauma, sometimes it's even nothing really sometimes you don't know exactly what caused it. But if you do have any inflammation of these cartilages, you get really painful. You get a painful sensation in your chest. I've had it 4 times in my life. So the first time I had costochondritis, this is when I was living in Dominica. We were surfing, and to get into the water where we were surfing, you have to jump into the water with your board because there was no beach. It was just all rocks, and there was this little tiny cliff ledge that you have to jump over using your surfboard. And so my buddy's like, all right, it's just easy. Just, jump in with your surfboard. I'm like, okay, cool. So I watched him do it. So I went afterwards. So I was holding the surfboard out like this. And as soon as I hit the water, the board came slamming into my chest and knocked the wind out of me. I thought I broke my ribs. I almost freaking drowned. And so I managed to make my way back to the beach. And I stopped surfing that day. And I couldn't sleep that night, because I thought I broke my ribs. And if you break your ribs, it hurts so bad that you can barely breathe, you can't laugh, you can't sneeze, you can't cough, and also it's really hard to get comfortable when you're laying down at night. So I thought I broke my ribs, and I was doing my rotations at the main hospital on the island, and my supervisors, actually we were doing radiology. And so the radiologist is like, hey, your chest hurts. We're going to first do a physical exam on you. And my colleagues did the exam on me. And also, we're going to send you to get a chest radiograph to see if you actually did break your ribs. And so they did the physical exam on me. And one thing that you do on physical exam for costochondritis is if you can elicit the chest pain by pushing on it, that's when you know it's not an MI, right? Because you can elicit the pain by pushing down on the area that might be affected. And, I guess you could still get that with a broken rib too. So you'll get chest pain on you can elicit that. But then when we did the x-ray, I didn't have any broken ribs. And so that's costochondritis. If you don't have broken ribs and it's just inflammation of the cartilages, then that's costochondritis. Once you get costochondritis once, you're kind of predisposed to it afterwards. So I've had it 3 times since then. The second time I got it, one of my stupid friends, super tall dude, decided to give me a bear hug, and I just heard it go pop, and I'm like, oh my God. So I got costochondritis again from that. I could barely sleep. I could barely move. And it takes about 3 to 4 weeks for it to heal. The other time I was in a snowball fight, and then I slipped on the ice and landed badly, and I got it from there. And then the last time I got it, so my dad, I told you guys already, he had a stroke last year, and it was about 3 or 4 months ago. I was picking him up from his wheelchair, and I heard that pop in that same spot, and again, costochondritis, and it took 4 weeks for it to feel better again. So yeah, it happens over and over again once you get it once. And for some reason, this is kind of embarrassing, it happens more in women than men. So I don't know if that has to do with muscle mass. I'm not exactly the most buff dude on earth, but I guess the more muscle mass you have, the more you're protected against this, and women generally have less muscle mass than men. So. Anyways, so sharp pain, inflammation. It gets worse when you cough, on deep breathing. Physical examination will show you can elicit it just by pressing on the area that's affected. And it's usually associated with trauma, right? So you might have had a direct injury like I did when I was surfing. But you can also see that there's no underlying cause for some people. It could be neurological. It could be muscle issues. So I don't know, but oftentimes it's going to be trauma. You can see it with certain infections as well, but not very common. And then treatment, that's all you do is just take NSAIDs, right? Because it's it's inflammation, right? So to treat it, you just take an anti-inflammatory. I would highly avoid giving somebody opioids to treat costochondritis. If I can survive costochondritis by taking ibuprofen, then so can most people. And I wouldn't want to inadvertently give somebody an opioid addiction, just to treat a bruised rib. So anyway, so that's why costochondritis is on there. It could look like a heart attack. You do an EKG on the person, perfectly normal. So that's costochondritis. So let's talk about the heart now. With the heart, of course, when we talk about cardiovascular disease, we're going to be referring to the blood vessels of the heart, the coronary arteries. And so the main coronary arteries that we're concerned with are going to be the LCA, so that's going to be the left coronary artery, and the right coronary artery, the RCA. What's another term for this one over here, the left coronary artery? There's a colloquial term for it. Yeah, the widowmaker. Good. Yeah, so why the widowmaker? First of all, heart attacks affect men more than women. So more guys die of heart attacks than women do. Yay. So thus, more widows, right? Another thing too, with that one specifically, the left coronary artery is going to be providing blood to the left ventricles, as well as the intraventricular septum. And if you damage the left ventricle, you're not able to pump blood out to the rest of your body, right? And so way worse to get an LCA occlusion than the right side. It's bad too on the right side. You're still going to have to get treatment for it. You're going to have to get a stent or a CABG, coronary artery bypass grafting. But generally speaking, if you wipe out the left ventricle, that's bad, really bad. Because now the rest of your body can't get blood. So that is the widowmaker. So what's going on with arteriosclerosis? So arteriosclerosis, that's just basically thickening and hardening of the vessels. Atherosclerosis, similar thing. It's just a kind of a subcategory. Arteriosclerosis is going to be associated with macrophages. So what happens when you have both hypertension and hyperlipidemia? What is the hypertension doing to the actual vessels? What? It's causing stress, and that stress can cause microvascular damage. So you get little tiny damage, pieces of damage or sites of damage in the endothelial layer of the vessel. And as you get damage, now you get an inflammatory process taking place. Macrophages are going to start going there to try to clean up the damage. Then with hyperlipidemia on top of that, then you have the macrophages start taking on lipids. And so you start getting these foam cells. That's what it's called. And when you have foam cell accumulation, that's when you have arteriosclerosis. And so it could get to a point where eventually you can get a full-on occlusion of that vessel. And so this whole entire process, that's the major thing going on with coronary artery disease, as well as cerebral vascular disease. And what are the risk factors? Sometimes you can't control the risk factor, right? You have non-modifiable risk factors. Us dudes, that's one of the risk factors, being a guy. Another risk factor, being older. And then family history. If you have a dad or a first-degree relative, like a brother or a sibling, that had a heart attack, your risk of getting a heart attack is way higher than the general population. And so it's good to know what your family history is, because that can help you modify things in your life, right? So the modifiable risks are the things that you can control, right? You can control your smoking. You don't have to smoke cigarettes, but I know it's hard to quit. I've had friends that have quit multiple times. It's really hard to quit smoking. So don't smoke cigarettes. Cigars, you don't really inhale cigars, so cigarettes is kind of like the main thing that's not great. But cigars, I guess, can cause mouth cancer too, oral cancer, so not necessarily a great thing. But, cigarettes are definitely worse, though. Hypertension, you can control that, right? You can take beta blockers, you can take drugs that can help reduce your blood pressure. You can reduce sodium intake, right? If you have a low salt diet, that can help reduce your blood pressure. Diabetes, you can control that, right? If you have proper glycemic control, you take your meds, right? That can be controlled. So sedentary lifestyle, right? This is like something we see, especially in the West, where we tend to be a little lazy. So if you're sedentary, maybe you're a desk worker and you live your life in a cubicle, you sit in front of a screen all day, like probably most of us do. You have to try to increase your activity. Chronic inflammation, right? A lot of diseases have an inflammatory component to them. So inflammation is a bad thing. So chronic inflammation can cause cerebral vascular disease, can cause strokes, can cause cancers, right? So inflammation is not a good thing. Obesity, hyperlipidemia. If you have low HDLs, that's also a risk factor. So LDLs, that's your low density lipoproteins. We refer to it colloquially as the lethal cholesterol, because the L. HDLs is the good one. If you have high LDLs, very bad. If you have high HDLs, that's actually really good. So you want to have high HDLs. That's the quote unquote good cholesterol. So what's going on with LDL? So LDL transports cholesterol and triglycerides to different organs in your body. That's the bad one. Your HDL is the one that removes extra cholesterol and then transports it back to the liver. So that's a good one. So that's going to be reducing your bad cholesterols in your body. And speaking of lipids, so saturated versus unsaturated fatty acids. Saturated, bad. Unsaturated, good. Reason being, if it's saturated and it has just a straight line of carbon-carbon bonds, and you don't have that kink in it, then those get lodged into places and they stay solid at room temperature, right? So anything basically that stays solid at room temperature is going to be falling under saturated fatty acids. Those can get lodged into your phospholipid bilayers in the cells, and it can get lodged into all sorts of different places. So that's not good. Versus unsaturated fatty acids, just because of that kink in the carbon-carbon bonds, you're going to see that those are going to be liquid at room temperature. So things that are liquid at room temperature tend to be a little bit healthier. So these are your good fats, right? So avocados, olive oil, the fats that you find in fish, especially with fish, you have omega-3 fatty acids as well, which are really good. Not as great, like fats that you find in meat products, sometimes cheeses as well. And then the trans fats are the ones that are really bad. You want to try to avoid those. So olive oil, good. Avocado, good. Of course, in moderation, right? You want to just drown everything in olive oil, but it's mostly good for you. Coconut oil, I love coconut oil, but coconut oil is actually kind of not that healthy. So it tastes great, and I love it. Butter is pretty high in saturated fats, and then beef fat is pretty high in saturated fats as well. So what's going on with the progression of plaques? Let's watch a little video of this, or a little step-by-step animation. So the first thing that you see happening is you get LDLs might be starting to get deposited, and then you start developing an inflammatory process. You're going to start seeing macrophages being recruited to that site. As more lipids start accumulating, that's when you get the foam cells being produced as a consequence. And then that's when you start getting the occlusion of the vessels. And then if you have plaque rupture, that can result in things like emboli, and it can also result in full-on thrombosis taking place. And so if you have thrombosis at that site, that's where you get ischemia. So ischemic heart disease, right? That means that you're blocking the vessel. And ischemia, if left untreated, turns into an infarct. And when you have an infarct, that's where you have irreversible damage to the heart, right? So let's go back a little bit to our A&P. You have 3 different types of muscles in your body, right? You have skeletal muscle, smooth muscle, and cardiac muscle. One of those types of muscles can reproduce, undergo mitosis. Which ones were those? Do you remember? No. Skeletal muscles actually do not undergo mitosis. Smooth muscles do. Skeletal muscles, like when you go to the gym and get jacked, those are hypertrophying. So you still have the same number of skeletal muscles, but they're going to get larger, right? And with cardiac myocytes, you can get hypertrophy as well. There's hypertrophic cardiomyopathy. That's not a good thing, right? You do not want a big buff heart because you're not going to be able to pump blood effectively. It's going to reduce your cardiac output, and you're going to have reduced left ventricular fraction for output. So that's not a good thing. Where was I getting at with that? Oh yeah, if you kill the cardiac myocytes, they're not going to reproduce, right? So ischemia, if left untreated, becomes an infarct. That heart tissue dies, and it's irreversible damage at that point. So definitely not a good thing. So that's why when you have a heart attack, you want to get that person treated immediately. You want to have them, you want to give them like aspirin. You want to do the whole monotherapy, right? So you want to give them morphine for the pain. You want to give them oxygen. You want to give them nitroglycerin. Nitroglycerin helps to dilate. You want to give them aspirin so you can thin their blood. And then you want to get them to either have a stent in place, right? So you do that at the cath lab. They'll take a little catheter and place a stent into the occluded vessel. Or if it's really bad and you can't stent, then you want to do CABG, which is coronary artery bypass grafting. How do we do CABG? Yeah, you can use other veins too, but the most common one is the greater saphenous vein. So you take that great saphenous vein, cut off a little piece of it, and then you reroute the circulation. You go around the area of occlusion so you can still provide blood downstream of that vessel. So you can have that from the great saphenous vein, and there's other vessels too. I don't know all of them off the top of my head, but you guys downstairs had an interesting one that had a part of the radial artery. The whole radial artery was used for a CABG. How many grafts did they have? I think it was like 4 or something, right? Yeah. So that's in the cadaver lab over here on campus. So the person was missing a radial artery, and they had several cabbages done. So the most I've ever heard of was five, like a five bypass, so like a quintuple bypass. So that was actually, I remember, yeah, it was my ex-girlfriend's stepdad. And unfortunately, he passed away since, but he, yeah, had quintuple bypass surgery. Absolutely insane. Then the guy got coronavirus. He survived that. He had a stroke. He survived that. Then he had another stroke, and the second stroke is what ultimately killed him. But pretty wild stuff. So anyways, this is the whole process. You get, is the combination of hyperlipidemia and hypertension. You get like microvascular damage. Macrophages come to the site of injury, start gobbling up lipids, start creating a plaque, and that's in the form of a foam cell. Plaques are also, you can find plaque developed not just in your coronary arteries, but you can get those in your carotids as well, right? You can get plaques built up in a lot of places in your body. A friend of mine, good friend of mine, he's an older guy, used to be my neighbor. He taught me how to play the harmonica. Cool dude. He's a party animal, so he drinks a lot, and he smokes a lot, and he does a lot of drugs. Last I spoke to him was like a year ago or so, and he told me that on the right side, his carotids, 100% occlusion. Nothing is moving through that right side of the carotid. Left side on the carotid was 80% occluded. So dude is a ticking time bomb for either a thrombus in his carotids or a stroke, like an embolic stroke, because you can get thromboembolism, right? Or sorry, it can get an embolism of if you get dislodging of any of the fat. And so the surgeons don't want to touch him. You can do surgery. You can actually remove a plaque from someone's carotid arteries. You can do it, but he is such a high risk because he has one complete occlusion and the other one's almost totally occluded. The surgeons don't want to touch it because he would be a high risk for stroke on the operating table. So, yeah, scary situation. So I think he's not drinking as much nowadays, but I think he still smokes a lot. So I don't know. To each their own, right? So these are all the things that are taking place. You get LDLs. You also get microvascular damages too, just from hypertension. And then you get your macrophages coming to the site of inflammation. They're gobbling up lipids, and then they start developing a plaque. And then you might see plaque rupture, and that's going to cause a thrombus. So that is the underlying mechanism of plaque formation. So what happens in your coronary arteries when you have occlusion? If it's not totally occluded, you could still potentially have symptoms. Now, if you have a 50% occlusion and that person maybe is like having a hard time going upstairs, or maybe if they go jogging, they get really bad chest pain. The name for that is angina. Right? So angina is the term for chest pain due to either coronary vessel occlusion or spasms. So if you have vasospasms at the coronary vessels, that's called specifically Prinzmetal's angina. So it's a different type of angina. But if you have a 50% occlusion because of a plaque, that's going to result in angina on exertion. So they may be asymptomatic at rest, but it's going to be on exertion when you have increased metabolic demand for the heart. That's when you get that chest pain. There's a couple different types. There's stable angina. If the plaque is unstable and prone to ulceration and rupture, that would be unstable angina. And then if you get vasospasms, that's going to be specifically Prinzmetal's angina. And generally, when you treat these patients, of course, you want to, do diet, lifestyle modification, things like that. And if it's bad enough, you might want to, consider a stent. But generally, you would treat that person with baby aspirin, right? Take like an 81 milligram aspirin, or you could give them like nitroglycerin tablets. So if you take like sodium nitroprusside, nitroglycerin underneath the tongue, sublingual, that can go straight down to the heart, and nitroglycerin helps to vasodilate. And so that's how patients with angina, they usually carry a little pill case with them that have nitroglycerin tablets because they'll get these angina attacks regularly. So you basically, mechanism, you have reduced lumen size. And because of that, you have reduced blood flow. You can get that with exercise. You can get that with if you become tachycardic because of exercise. So not good. All right. So here's another schematic of what that looks like. You might be seeing vasospasms, and then you could see things like thrombosis and stenosis, and that would reduce your blood flow. That would cause angina. If your heart rate is going up, you're going to have increased oxygen demands. Because of that, you can get angina. So if you don't have enough oxygen in that tissue, what's going to be accumulating because of anaerobic respiration? Lactic acid, right? The lactic acid is what causes that pain, right? That's like the underlying cause for the pain. It's the buildup of lactic acid in that area. So ischemic attacks versus myocardial infarction. So you can have transient ischemic attacks. Those can happen if it's less than 20 minutes. And what happens here? So you have reduced oxygen consumption, right? So you're in an anaerobic state. If that's less than 20 minutes, that's going to be considered an ischemic attack. If it continues beyond 20 minutes, now you have a myocardial infarction. Because remember, ischemia precedes an infarct. Ischemia is reversible. The infarction is irreversible. You're going to get irreversible damage. What happens if the damage gets to a point where it's severe enough? You might get an inability for those muscles to contract. If they cannot contract, you're going to get poor cardiac output as a consequence. You could also see damage that might interfere with the electrical conduction. And if that happens, you can potentially get an arrhythmia as a consequence. What's up? It could be like just a temporary occlusion, right? And it could maybe get dislodged, perhaps. It could. Yeah, it definitely could. But yeah, I mean, a lot of stuff can go wrong if you get a transient ischemic attack. But but by definition, if it's a ischemic attack, it's only less than 20 minutes and it subsides. This is a risk factor, though. Like, if you start getting these things happening to you, you're a ticking time bomb, right? Because eventually you're probably going to have an MI, right? That's why, like, unstable angina, for example, that is what the person is probably eventually going to wind up having a full-on myocardial infarction. But like I said, over 20 minutes, that's when you start getting irreparable damage to the heart, and that can cause, of course, dysarrhythmia, right? If you get a dysarrhythmia as a consequence, especially like ventricular fibrillation, that is really bad. If you get VFib, that's a pulseless patient. The patient will not have a pulse. They're not getting any blood moving whatsoever, and that would result in sudden death. What's up? That would be a good idea. And if they're getting chest pain, they should probably go see a doctor, like right away. They theoretically should call they should call emergency and try to get rushed to the hospital. Because chest, especially if it's a female, we'll talk about how it presents differently for males versus females. Females, y'all have a higher pain threshold than us guys. And so for us guys, that's, we have a heart attack, we get the whole like pain radiating to our arms, our necks, our back, we get the diaphoresis, all that stuff. For women, you don't really get as much as the chest pain. So it's more of like a silent thing for women. So if you had those symptoms, especially as a lady, I would really recommend going to the doctor right away, to the hospital, so you can get checked, get all your lab values checked, get your EKG done. And then if it's a heart attack, you have to go to the cath lab, right, to get either a stent, or eventually you might have to go to the OR to get CABG done. But yeah, if you're a sedentary person, hypertension, smoking, have chest pain, it could be angina. It definitely could be, but I wouldn't take that risk. As soon as the chest pain happens, I would definitely want to go get that worked up. That's a good question. So stable angina. Stable angina is reversible. It is a temporary ischemia. That's why you get that chest pain, because they have buildup of lactic acid. It's not going to last very long. It should only last about 3 to 5 minutes. You might see things that are similar to a heart attack, right? You could get radiation, that referred pain that radiates down the arm, up the neck, back to the back as well. You would get pressure, that feeling of pressure. The feeling of pressure is primarily due to that buildup of lactic acid, the pain associated with that. And you can get diaphoresis from that as well. You could get nausea. You could get shortness of breath. Those are all things that you could see with angina. But know that it is reversible. 50% occlusion. That's going to be what's going on over here. So this is the main common cause, is going to be occlusion of that vessel. And then subsequent to the occlusion, you have increased demand. Say maybe you're taking the stairs and you're getting exhausted walking up those stairs, and you can get lactic acid buildup causing the chest pain. So treatment, chill out, right? Get some rest, and then nitroglycerin. Nitroglycerin is like the gold standard treatment for angina. You just take a sublingual nitroglycerin, and it helps right away to dilate the vessels. So, how could you tell if it's what? Well, yeah, that would be hyperlipidemia is definitely going to be an underlying cause. That's going to be an underlying cause for like everything that we're talking about today. So you would also want to get the patient's history and story, right? The history of present illness is going to tell you a lot about the patient. They're going to tell you when the chest pain happens, how long it lasts, right? The things that precede it, the things that cause it. So you're going to get that history, and then you could do a radiograph as well, so you can see what the perfusion is. So you can inject them with dye, so you can do this type of perfusion analysis on the patient, so you can see if those coronary arteries are occluded or if they're getting good circulation. So these are the tests that you can do, right? So you can do CBC, you could check cholesterol, so that they're hyperlipidemic, right? They are going to be a risk for atherosclerosis. These tests are kind of weird. I'm not a big fan of CRP. I mean, it tells you something is going on, but CRP and ESR, so CRP is C-reactive protein, it just tells you that there's inflammation. And remember that a lot of this is going to be due to inflammatory processes. And so all that macrophage accumulation, the foam cells, that's all inflammatory. So CRP is going to tell you that there's something causing inflammation. ESR is another thing. The erythrocyte sedimentation rate is another thing that just tells you, oh, okay, there's inflammation going on. That just means you have to further investigate. But then you can do perfusion. You can do perfusion studies as well to see if the dye is making its way down the blood vessel if it's well perfusing, right? If it's well perfused, or if there's a little bit of a occlusion taking place, there's some blockage going on. So you can do those types of studies as well. Let's watch a little video.
Monitoring your EKG, and we also take special images of your heart looking for a blockage. Dr. Harisi will talk about this a little bit.
I'm Dr. Harisi, a cardiologist here at the Lying Medical Group. And as Joe mentioned, some people, in addition to their treadmill exercise test, will require nuclear imaging. And that is a procedure where we inject a harmless amount of radioisotope tracer, and we put you under what's called a gamma camera, which you saw in the previous picture. And we get images that look like this. It looks like a circle and a horseshoe. Now, this is the heart muscle. If it's complete like this, it's normal. And if there are parts missing, as you can see in these images, then that means there could be a potential problem with blood flow to the parts of the heart muscle and require further testing. These are very important tests. We do them every day. And if you have any questions, you can give us a call. And thank you for visiting the non-invasive lab at Lying Medical Group.
Okay. So in other words, run tests on the patient just to see exactly what's going on with them. So you can do a couple different tests. You could do a stress test where you can put the patient on a treadmill and induce ischemia, right? So you're increasing the demand to the heart. You could do angiographies, right? So you're literally injecting the patient with dyes. Pretty non-invasive type of study. So you just go in through the femoral, is it the femoral vein? What is the femoral vein? And then you're going to be injecting dye so that you can see if the coronary arteries are actually getting any perfusion or if there's an occlusion. I think it's actually might be the femoral artery. So don't quote me on that. Anyways, not important. You're not going to get tested on that. So myocardial ischemia, right? So you have ischemia that would be lasting a short period of time, but if you have ischemia that eventually turns into an infarct, that would be a myocardial infarction. So 20 minutes is kind of the general duration, general amount of time, after which you would start getting irreparable damage. You wouldn't be able to reverse it. But if it's before 20 minutes, if it's less than 20 minutes, then you could potentially see reversing. Something else that you're going to see too with ischemia, so with angina, you might see ST segment depression. We're going to talk about ST segment elevation. That's STEMI. That's going to be the more severe types of damage to the heart. But with transient ischemia, then you're going to see ST depression. If, however, if that turns into a full-blown heart attack and it becomes transmural, which means it affects every single layer of the heart muscle, then you would get ST segment elevation. So that would be considered a STEMI, ST elevation MI. So we're going to talk about those in a second. So here is what's going on at your SA and AV node, the red line, and then the black line is what's going on at the cardiac myocyte. So this is where you have depolarization and repolarization. So at the P wave, you're going to have depolarization of what? Do you remember? Atrial depolarization at the P wave. What's going on at the QRS complex? So atrial repolarization and ventricular depolarization. And then you're going to have over here, when your ventricles depolarize, that's when you're going to see the contraction take place. At 2, that's where calcium enters, or that's where calcium allows for the cardiac myocyte to fully contract. And so that's going to be where you see ventricular contraction at 2. And then at the end of everything, you're going to see the T wave, which is going to be what? Huh? Yeah, it's going to be involving potassium. It's going to be ventricular repolarization at the T wave. And yes, you're going to see that potassium is going to play a heavy role in that. So at the ST segment, that's where you see ventricular contraction. And you can also see ST changes on different types of conditions. So we'll talk about what those look like in a moment. So you can have ST elevation, you can have ST depression, and those are each going to be associated with different types of conditions. So if you have acute coronary syndrome, that's where you have the thrombus being involved to block that vessel. This could be due to rupturing or ulceration of that plaque. If the plaque ulcerates, then all of a sudden you're going to have a thrombus coming in to that area. And so you'll get full occlusion of that vessel. And so this would result in unstable angina, and if left untreated, myocardial infarction, where you get actual full-on damage, irreversible damage to the heart muscles. If it is subendocardial, that's where you don't see ST elevation. But if it's transmural, that's where you do see ST segment elevation. So this is what you mean by transmural. If it is involving every single layer of the myocardium, then that's transmural. It's going to be everything from the inside to the outside of the heart. And so every layer is going to be involved. And in those cases, that's really bad. And you are going to see ST elevation in the areas that are affected. ST elevation on the patient's EKG. However, on the other hand, if you don't get full involvement of every single layer in the myocardium, then that would result in non-STEMI. So you don't see, you might not see ST changes in those patients. So unstable angina, this is reversible unless it makes its way into the realm of infarct. If it's infarct, then that is a myocardial infarction. But unstable angina can be treated, and you might not have any damage to the heart at that point. But it is the steps leading up to a full-blown heart attack. And then this is the main thing that I want you guys to pay attention to is ST segment depression would be seen in angina, but if it became transmural, then you would see that shift to ST elevation afterwards. So ST depression would be associated with angina, and then you might see T-wave involvement too. You'll see T-wave inversion. So myocardial infarction, this is where it's irreversible. You're not going to go back from this. The cardiac myocytes are damaged. They do not reproduce through mitosis. So that's it. You have permanent damage to the myocardium. And then so if you see that damage, if it's subendocardial, then it's going to be a non-ST elevation MI. And if it is transmural, that's when you see ST elevation. And so it's going to go all the way through every single layer, all the way to the epicardium. So here again, you see subendocardial MI is non-STEMI. The thrombus basically disintegrates, so you only get partial necrosis. It's not transmural. Whereas with transmural, you're going to see everything is going to be elevated. The ST elevation is going to happen with transmural type myocardial infarctions. So we'll go into the EKGs in a little bit. So I'll kind of show you how to interpret the EKG. I will say that EKG is not exactly like my total 100% forte. They can be pretty challenging to read. But if it's with practice, right? The more you read an EKG, the better you get at interpreting it. So some of you who work in emergency, Trent, are you pretty good at reading EKGs? Yeah, okay. So it's pretty obvious when you see a STEMI, but there's all sorts of different types of arrhythmias, like heart blocks and things like that. All the different types of heart blocks, they can get kind of difficult to read and interpret on EKG. But I'll show you how to interpret the basics for an EKG. All you really need for the sake of this class. So this would be ST depression, and then this would be ST elevation. When you see depression or elevation, you're going to be comparing it to the line directly after the P wave, right? So the PR interval is going to be this region right here. That's what you use as the basis, okay? So that would be normal, right? But if it's below that PR interval, then that's going to be ST segment depression. If it's higher than the PR interval, that's ST elevation. So if you see ST elevation, probably a STEMI, very severe form of myocardial infarction. So what are the signs and symptoms of a myocardial infarction? Chest pain is going to be like the number one thing that you see in these patients, right? They're going to be complaining of a very intense 10 out of 10 chest pain. It's going to feel like they have something sitting on their chest, right? Some people say, it feels like there's an elephant sitting on my chest. They have the chest pain and they have a really hard time breathing. And so they're going to have shortness of breath as well, right? They're not able to pump out the blood properly. They're going to have chest pain because of lactic acid. And then they're also going to have shortness of breath because they're not able to get oxygen delivered to their tissues. So you get dyspnea, chest pain, shortness of breath, nausea and vomiting because there's going to be certain nerve fibers that are going to be affected. And so because of that, it's going to send signals to your brain to induce vomiting. So you will see these patients throwing up. Of course, anxiety, right? You don't know what's going on. You're freaking out. So you're going to see anxiety, diaphoresis, which just means sweating. And then you're going to get cold and clammy hands because of peripheral vasoconstriction. And then you're going to see blood pressure changes. So it could decrease, and then you might see increase as well. And so in terms of radiation, where is the pain radiating to? So it's going to be shoulder, left arm, neck, jaw, and to the back as well. Yeah, so women present a little bit differently. So we'll talk about that in a moment. There's a video too that I'll show you, so you can see what it looks like when a woman has a myocardial infarction compared to a guy, because that is key. Lots of women die because they don't get the treatment when they actually have an MI, because it presents differently than how it presents for a male. So that's really important to know. And then we already talked about all the risk factors with cardiovascular disease and stuff. And if you get a transmural MI, sometimes because of the necrosis, even if the person survives, later on, like 5 days later, this can rupture. And so they can actually get a rupture directly through the ventricle, and then that would cause cardiac tamponade, and the patient would probably die at that point. So even if they do survive the MI initially, you could still die afterwards. So these are all the signs and symptoms. So chest tightness, feeling like you have an elephant standing on your chest. It is sudden onset, right? Because you have that thrombus all of a sudden like develops, causing ischemia, and then infarct. It's gonna be substernal, right? So directly below the sternum. What else here? You can relieve it with nitroglycerin. It's gonna radiate to the back, neck, jaw, shoulder, arm, dyspnea, syncope. Syncope. What does syncope mean? You passed out, right? So this would be cardiogenic syncope. There's neurogenic syncope as well if it's neurological. But if a person passes out, you definitely want to get an EKG on that patient to see what's going on, what's the underlying cause. So you can see syncope, of course, nausea, vomiting. We talked about that already. Diaphoresis, denial. Sometimes a person is trying to pretend that things are okay. So, anyways, those are all the signs and symptoms. So this is where we talk about the difference between males and females. Guys are going to present with all those classic symptoms: chest pain, diaphoresis, nausea, vomiting, all that stuff. However, for women, you might see some things a little bit different. They're going to present a little bit different with maybe like a little bit of a discomfort. They might get a little bit of the arm pain. Women might get the nausea and vomiting, the jaw pain, and radiating to the back. So let's watch a little video talking about how things like this present with women.
Okay? Sure.
Where are your shoes? Put your shoes back on, please. We're going in 3 minutes. Oh, what am I doing? I forgot to cut off the front. Cut off. Shoes on, call if you need it. Get your sister. Oh, yeah. Mom, you're having a heart attack. That's a heart attack. Totally fine. Don't forget to wear the high socks with the shin guards. What do you know about the shin guards, Mom? Come on, Mrs. Otto is not going to wait. I'm sorry to bother you. I think I might be having a little. Nothing really, just some nausea. Fogginess or breath, terrible 2 minutes. I thought I had gas. Turns out I was having heart disease is the #1 killer of America. So now I take care of my heart and I tell the women that I like to do the same. Maybe your mission is to save your life. And the last women you love, find out more from the American Heart Association. GoBackForWomen.org.
Right. So different types of presentation between men and women. All right. So what do you do when you have a patient that has a heart attack or you're suspecting that the patient has a heart attack? You want to do a workup on the patient right away. The sooner the better. So EKG right away. You just do a 12-lead EKG on that patient to see what's going on or what areas of the heart are being affected. Blood tests. This one is the most important of all the blood tests. Troponin is going to be the most important. And then CKMB is also going to be very important, but troponin is going to be the most specific. But CKMB not as specific, and myoglobin, again, not super specific. And then in terms of what rises and falls, the one that rises and falls earliest is going to be myoglobin. Myoglobin is going to be released from any sort of damaged heart muscles. It can also be released from damaged muscles in general. So that's why it's not super specific for cardiac muscle. You're going to see a rise in CKMB and troponin. Troponins are going to linger longer. So they're going to last up to like 4 days. So you'll be able to detect that for quite a while after that initial damage to the heart. So know that troponins are going to be the most specific and they last the longest in the blood. CKMB is going to be the second most specific, and it's going to be the second one that lasts a little bit longer. And then the one that's the least specific and the one that lasts least in the blood is going to be your myoglobin. So troponins, you can see it for several days. Myoglobin is going to be quick, it's going to be 24 hours, and then CKMB can also be a few days. But troponin is going to last the longest. So troponins are going to be part of your actin filament. So you have actin and myosin that allows for contraction. If you have damage to the heart muscle, you're going to see things like CKMB as well as troponins free floating in the bloodstream. And you can detect that on different tests. So let's talk about ST elevation versus ST depression. So STEMI, ST elevation, is by far going to be the most troubling of the findings on an EKG. So acute MI, that's going to be the main thing that I want you to think about. Brugada syndrome, do not worry about that for this class. It is just something that causes irregular heartbeat. And actually don't really worry about any of this other stuff so much. Hypertrophic cardiomyopathy, we're going to talk about later. Left branch bundle block, that's what LBB stands for. That means the fibers that provide the ability for depolarization in the heart on the left side are going to be blocked. So you might see ST elevation from that, and you can see global ST elevation on pericarditis. And we're going to talk about pericarditis, I think, at the end of the second or third section in this series. So we'll talk about what pericarditis looks like later on. ST depression, the one that I really want you to pay attention to, where's that? It's not on this list, but yeah, never mind. Angina would be something that you would see with ST depression. But all these other things can cause ST depression as well. So not super high yield for this class. But know that ST elevation is a very scary situation. So 12-lead EKG, how do you place the leads? So there's going to be leads 1, 2, and 3. So the first one, it's going to be on the sternum. Leads 2 and 3 are going to be on the lower sides of the ribs. Then you have your V1 through 6. And V1 is going to be on the right side of the sternum. V2 is going to be on the left side of the sternum. And then the rest are going to follow along, kind of like along where the apex of the heart would be. And then you have your AVR, AVL, and then your AVF, which would be lower. So this is another schematic to help you kind of see where these leads are pointing to. So AVF is going to be the lower axis. AVR and AVL are going to be the right and left axis. Then you have your V1s through 6. And so depending on what part of the heart is affected, you'll see that represented on these different leads. So if you had, for example, lateral side of the heart or the left side of the heart, you would see AV1 being affected in the EKG. You would see AVL because that's on the left side, that's the left axis. You would see AV5 and 6, right? Because these are the ones over here on the left, on the furthest left side of the heart, right? So those are the major leads that would be affected. If you had a left ventricular MI, for example, the left coronary artery. If the left coronary artery got occluded, you would see these leads being affected. If it was the inferior part of the heart, you would see leads 2 and 3 and F, right? AVF, because that's going to be the axis pointing down. If it was on the anterior side of the heart, you would see 3 and 4. These 3 and 4 over here. And if it was septal, which means what's it called? Yeah, intraventricular septum, then it would be V1 and 2. So here's an example of an EKG that is demonstrating some changes. So let's see which parts of the EKG are being affected. So it should be, or you should already see it on your side. But let's just kind of go through each one of these. So remember, you look at the PR segment, and then you determine if the ST segment is elevated or depressed based off of the PR segment. So let's look at lead 1. So here's your PR segment right here. That's your ST segment. So that's a STEMI, right? So it's ST elevation. So you have ST elevation in 1. Then you look at AVL, that's left, right? So you have elevation in the left lead, V2, V3, then you see V4, 5, and 6 being affected as well. So this is a left-sided STEMI. So this is going to be involving the left coronary artery. And it's going to be causing damage to the left ventricle. So that's ST elevation, MI, you're not getting any of the blood. If you saw ST segment depression, that's with like ischemia, right? So that'd be like angina, for example. So that's just decreased blood flow. But if you have unstable angina, that could turn into this. It could turn into an ST elevation MI. I'm sorry, what? That's just because it's affecting everything, right? It's just a really bad heart attack. Yeah. So so in this previous slide, showed you the ones to look at if lateral, so 5 and 6, those are going to be the ones that are furthest to the left. But if it's like really bad and it's affecting more of the myocardium, then you could see other leads getting involved as well. So that's a great question. Yeah, because it's going beyond just the V5 and 6. It's also impacting V4, 3, 2. Not a good situation. So that's a really severe heart attack. What's going on with this EKG? You already have the answer on your side. I should have blocked it so you guys can think about it. But let's look at it in terms of the leads. So you got lead 1. You see elevation in lead 1. Then you see elevation in AVL, right? And then elevations in 2, 3. This is the same thing as the last one. So it's going to be the left side of the heart, right? So you're going to see anterior lateral, but it's going to be left side. Anterior lateral STEMI. So what's going on with this one? This one's kind of interesting. We'll talk about this later, but where's the ST changes? There's ST changes in 1. There's ST changes in 2. Kind of hard to see 3. Looks like there might be a little dip. Kind of a hard one to look at. Let's look at lead 2 here. Yeah, you can see those changes all across lead 2. AVR, you're seeing some, it looks pretty strange as well, right? AVL is definitely elevated. AVF is elevated. Everything is elevated, basically. So this is an example of pericarditis. So if a person has pericarditis, inflammation of the pericardium, you're going to see global ST changes, ST elevations. Okay, so we'll talk about that later on, but when I first was looking at this EKG. I'm like, what the hell is going on here? It's like affecting every single one. It's not just one side of the heart, but it's affecting all of it because it's pericarditis. So that's a really good EKG to demonstrate that. So let's see, what time is it? Got some time. So this is the monotherapy, right? You want to treat the patient with morphine, oxygen, nitroglycerin, and aspirin. Morphine because they're really experiencing a lot of pain. You want to control the person's pain. You want to give them oxygen because they're not getting enough oxygen because they're not able to, pump the blood properly through their pulmonary circuit, and it's not getting pumped through the rest of the systemic circuit either. Nitroglycerin because nitroglycerin dilates vessels, so you want to maximize the amount of vasodilation in the heart. And then aspirin because aspirin prevent further thrombus from happening, right? Because aspirin is going to block the ability for platelets to be able to create more thrombi. You can give them thrombolytics as well, so you can bust the clot. That's a good thing to do, right? You want to make sure that the person try to treat that clot if possible. If they're hyperglycemic, give them insulin. And then these are other things that you can do that are more invasive. So let's watch some videos on each of these.
Coronary artery disease is narrowing of the coronary arteries secondary to several risk factors, some of which are cigarette smoking, hypertension, hyperlipidemia, and diabetes. Percutaneous coronary intervention, or PCI, is a procedure used to treat and evaluate partially and completely occluded coronary vessels. Atherosclerosis results from endothelial injury, inflammation, and accumulation of lipoprotein, leading to intimal deposition of particles and narrowing of the coronary artery. The stenotic vessel makes it difficult for red blood cells to pass through. Therefore, the risk of ischemia and infarction is increased. During the percutaneous coronary intervention, an incision is made to isolate the femoral artery. The catheter is inserted into the artery, guided up the aorta to the heart. Live angiography is used to guide the catheter to the obstructed coronary artery. Radiopaque dye is injected into the artery. Imaging determines the location of the stenosis and the diameter of the vessel. Once the vessel is isolated and the obstruction located, a guide wire is threaded through the catheter to the location. The catheter is removed, leaving the guide wire. A balloon catheter is pushed over the guide wire and centered over the blockage. The balloon is inflated to open the narrowed vessel. The balloon is inflated and deflated multiple times to gradually widen the occluded vessel. To ensure that the artery remains unobstructed, a second balloon catheter with a stent is threaded to the location. The balloon is inflated, expanding the stent. For some patients, drug-eluting stents are used to decrease the chances of in-stent stenosis. Drug-eluting stents are coated with a material that will retard new intimal hyperplasia. Blood flow through the coronary artery is restored.
All right. Cool. So earlier when I said femoral vein or femoral artery, when you do the dye, it's through the femoral artery. Let's watch another video on angioplasty.
An angioplasty is a procedure that opens up blocked blood vessels without surgery. During the procedure, the interventional cardiologist places a sheet into the artery in your groin or wrist. The cardiologist will guide a small catheter into the coronary arteries through this sheet. Then your doctor will inject a small amount of X-ray dye through the guided catheter. You may feel a warm flushing sensation at this time. This is normal and passes quickly.
The person's awake, by the way, when this happens.
Your doctor will watch the movement of the X-ray dye on a screen to identify where your arteries are narrowed. Your doctor may ask you to take a deep breath and hold it for a few seconds while taking X-rays, and ask you to cough after the X-ray is finished. This helps remove the dye from the arteries. If a blockage is found, a small balloon with a stent will be inflated at the site of the blockage, widening the blocked artery. It may be inflated several times to push the plaque against the artery walls and open the artery mouth. When the balloon is inflated, the blood stops
flowing through your artery for a short time. It's not long enough to cause damage to your heart. However, you may experience some chest pain. The stent helps to keep the artery open. Angioplasty takes between 30 minutes and 2 hours, depending on the number of blockages. Discharge from the hospital is usually 12 to 24 hours after the catheter is removed. Many patients are able to return to work within a week after a procedure. Although angioplasty is a less invasive way to open clogged arteries than bypass surgery, the procedure still carries some risks. The most common risks are bleeding at the point of injection and blood clots within the stent. These clots can close the artery, causing a heart attack. Taking aspirin in combination with clopidogrel is important to decrease clots forming in your stent. Thank you for watching this video. Please.
Yeah. So that's PCI. And then let's see what happens if PCI fails. So this is coronary artery bypass grafting.
During the conventional bypass surgery, your surgeon begins by making an incision in the skin over your breastbone or sternum. He or she will then cut the sternum and move your ribcage in order to get to your heart. Throughout the procedure, your circulatory system may be connected to a cardiopulmonary bypass pump or heart-lung machine. This machine may temporarily perform the functions of your heart and lungs during the surgery, allowing your heart to be stopped if desired while the surgeon sews the grafts into place. Different blood vessels may typically be used for the graft. The internal thoracic arteries of the chest, also known as internal mammary arteries, or the saphenous veins in the legs. For the internal thoracic artery graft, your surgeon will leave the upper end attached to the subclavian artery and divert the lower end from your chest wall to your coronary artery, just beyond the blockage. Your surgeon will then sew the graft into place. For the saphenous vein graft, your surgeon will suture one end to the aorta and the other end to the narrowed artery, just beyond the blockage. With the graft securely in place, your surgeon may use electrical signals to restore the heartbeat and attach a temporary pacemaker to the heart. Once your heart is again beating normal, if the surgeon used the heart-lung machine, it would be disconnected. Your surgeon will wire the breastbone back together and suture the skin incision closed. Temporary drainage tube will be placed through the skin beneath the incision. When the surgeon chooses to do the surgery without using the heart-lung machine, the heart continues to beat.
I'm not going to play any more of that. The wires. There's that body in the anatomy lab too that had that grafting done, coronary cabbage done. It was scary whenever you move the thoracic cavity because the wires are right there, and I almost like stabbed myself a few times on the wires because they have to wire the sternum back together. So it's a pretty invasive surgical procedure. It's brutal. So not great. Avoid it if you can. What do you do afterwards when you have a heart attack? Now you have to be on drugs, right? You want to go on beta blockers like Betalol, Metoprolol, all the LOL drugs. Those are your beta blockers. And then ACE inhibitors would help. What do ACE inhibitors do? How do those work? Good, yeah. So it's part of the RAS system, right? You got the renin, angiotensin, aldosterone system. And so angiotensin 1 doesn't really do much. Once it gets converted to angiotensin 2, that's when it's a powerful vasoconstrictor, right? And so that happens in the lungs. That's where you have your ACE, angiotensin converting enzyme. And so if you block ACE with an ACE inhibitor, then you don't get angiotensin 2, so you don't get the vasoconstriction. You also don't get the aldosterone involvement as well. So like it's good. It's good to take an ACE inhibitor if you had an MI. And then these are all the different complications that you might see with MI. So let's look on the right. Let's look at pericardial inflammation, pericarditis. If you have any damage to the electrical circuitry, right? If it interferes with, the transmission of a circuit from the SA to the AV node, and you get like reentry type problems. You might get atrial fibrillation as a consequence. You might block some of the branches and get like a left or right branch bundle block. Those triple Bs or right R triple Bs. So that would result in arrhythmia. If you get necrosis, remember I said that even if you get treated for a transmural MI, like 5 days later, 7 days later, that necrosis could eventually rupture. And then what would happen after that? Blood floods into the pericardial sac, and then you get cardiac tamponade. And if you get impaired contractility, you get things like cardiogenic shock, you can get congestive heart failure, right? Left and right congestive heart failure. Left side, you get edema systemically. Left side, you would get pulmonary edema, which could eventually turn into right side heart failure over time. And then you can get thrombi as well. Thrombi, whenever blood doesn't pump well, the blood pools, you get thrombus, and if a little bit of that thrombus breaks off, now you have a thromboembolism, and that could lodge itself into the brain, causing stroke. So those are all the complications of MI. Any questions on the heart? Rock and roll. We're not going to do this. I don't even have any questions for you guys yet on the quizzes, so I'll build those out for next time we meet to finish this next week. So we'll start here next week, and I hope you guys do good on the exam on Friday. So it seems like you all have a pretty good hang of everything that we've been talking about, so I think you'll do well. No, absolutely not. No, we're taking the exam. We're getting the hell out of here. So it's 30 questions, and I'll give you an hour to complete the exam. So lots of case studies. Yes. There's like a couple smaller, like simpler questions, but a lot of them are going to be so-and-so, passed out due to dehydration. I don't know. It's going to be like lots of different little vignettes. I've been giving you 1,000 questions. So you have all those quizzes questions that I prepared for you. They're very similar to the exam. Very similar. Yeah, they're all embedded within your PDFs. Yeah, so you can access that. Those are open. Anybody can access those, not just you guys. They're actually public, so yeah. Yeah, have a good one. Cheers.